Hello and welcome everyone. Thank you for joining us for today's webinar, Ask the Experts, Together Overcoming Barriers in Women's Heart Health. So just our land acknowledgement. In her book, Breathing Sweetgrass, Indigenous Wisdom, Scientific Knowledge, and the Teachings of Plants, Dr. Robin Wall Kimmerer reflects on the meaning of land to Indigenous peoples and rights. In the settler mind, land was property, real estate, capital, or natural resources. But to our people, it was everything: identity, the connection to our ancestors, the home of our non-human kinfolk, our pharmacy, our library, the source of all that sustained us. Our lands were where our responsibility to the world was enacted, sacred ground. It belonged to itself. It was a gift, not a commodity, so it could never be bought or sold. These are the meanings people took with them when they were forced from their ancient homelands to new places. Therefore, we would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So welcome. It is February 13th. It is We Are Red Canada. Thank you all for joining today. So just a few housekeeping notes before we get started. Participants have been muted and videos are off to minimize disruption. If you have any questions or technical difficulties at any point during the webinar, we welcome you to type them in the Q&A section. There will be a live question and answer period at the end of the webinar. Due to this public platform, we ask that your questions be general in nature. And we will have a poll at the starting of the webinar. Participation is optional and all answers are anonymous. And lastly, there is a short follow-up survey that will appear in your browser window at the end of the webinar. This survey will also be sent to you via email in case it does not show up in your browser window. So first, we'd like to dive into our poll.
Okay, so, I'll introduce myself.
Yeah.
Okay. So
we're just trying to get an idea of who's in the audience today. If you're a woman with lived experience, a caregiver, healthcare professional, trainee, or if you're a researcher, or if you're here just to learn more about the topic, feel free to jump in and let us know who you are. We're almost there, and we're going to share those results now. All right. So we've got quite a few women with lived experience. A lot of you would like to learn more about the topic, and we have several healthcare professionals and a few trainees and researchers. So with that, I would like to just quickly move over to introducing our moderator for today's session. Dr. Judy Liu is a woman with heart health, is a heart health cardiologist with expertise in cardiac MRI at McGill University in Montreal, Quebec. Dr. Liu will be developing a dedicated clinical and research program to improve the diagnostic and therapeutic management of women with heart disease. Dr. Liu currently serves on the executive steering committee of the Canadian Women's Heart Health Alliance as co-chair of the advocacy working group. Dr. Liu.
Thank you so much, Melissa, for that introduction. And thank you, everybody, for joining us on this very important webinar today. I would just like to do a quick shout out for Wear Red Canada. And we're so excited to be celebrating our 5th annual Wear Red Canada. And it's with the ultimate goal, as you all know, to raise awareness about women's heart health. And as part of our 2023 campaign this year, there are both virtual and in-person events held across the country, including today's national webinar. And so please do take a moment to review the list of the in-person online events on our events page that will pop up in the chat box here. For some of you who are joining this webinar, that's definitely one way to participate, but there are many other ways that you can participate today. You can share our 5 key messages. You can follow us on social media with hashtag Her Heart Matters, hashtag Wear Red Canada, and also follow us on Twitter, Instagram, and our Facebook group. And across the country, in many dozens of cities, provinces, territories, they're doing proclamations about Wear Red Canada being February 13th. There's buildings and landmarks that will be lit red, all in support of women's heart health. So please do join us as we work together to make the campaign the best yet. Next slide. And so for today's webinar, thank you for joining us. We're going to be talking with our expert panelists about raising awareness, not only for women's heart health, but how we can together as a nation reduce barriers to optimizing cardiovascular care for women. This is very briefly the agenda that we have. We'll be meeting all of our expert panelists very shortly here. Bobbi Jo will be sharing her piece as a woman with lived experience. The majority of the webinar will be a question and answer period, both from our expert panelists and members in the audience. So you do have a chat box and an opportunity to enter your questions into the Q&A session. I'll be moderating that and looking at your questions, and a lot of these will come up during the session. And then finally, we'll close in the last 5 minutes with our conclusion and our closing remarks. So without further ado, I'd like to take the time now to introduce our panelists. We have, and everybody will wave as I mention their name, we have Dr. ALEXANDRA BASTIANY. She is an interventional cardiologist in Ontario, Canada. She earned her medical degree and completed her cardiology training at the University of Montreal. She graduated with honors as the UDM Faculty of Medicine's first Black valedictorian. Dr. Bastiani then successfully completed a fellowship in interventional cardiology in Alberta, making her the first Black female Canadian interventional cardiologist. Combining her expertise in cardiovascular disease and her passion for community work, Dr. Bastiani is actively working to decrease the race and gender biases that are leading to differences in standard of care and clinical outcomes. Next, we have TAIRA BIRNE. She is a lead case manager for the SCAD, so Spontaneous Coronary Artery Dissection Rehabilitation Center at the Leslie Diamond Women's Heart Health Clinic in Vancouver, BC. TAIRA is also a person with lived experience after being diagnosed with arrhythmogenic right ventricular cardiomyopathy, or ARVC for short. And she did, in fact, receive an implantable cardiac defibrillator, ICD, in 2022. She is keen on sharing her experience and knowledge with women and others who are affected by heart disease, both from a healthcare provider perspective and a patient point of view. Next, we have here Bobbi Jo GREEN. It gives me great pleasure to introduce Miss Bobbi Jo. She's from Cape Breton, who now lives in Edmonton with her family. She's an elementary school teacher and an avid runner who was misdiagnosed for the better part of a decade. And this has interfered with both her career as well as her love of running. Her symptoms began at the age of around 28, 29, and she finally received an official diagnosis of coronary artery spasm or vasospasm, myocardial bridge, and endothelial dysfunction 10 years later at the age of 38. So she will share with us her profound story, her insights, and her recommendations as a woman with firsthand lived experience of heart disease. And finally, we have MOIRA. She is a long-standing advocate for engagement who has been witness to countless patient journeys in her many years as an acute social worker. Over the past 5 years, she has worked at a national level, developing organizational-wide frameworks and multifaceted toolkits for public and patient engagement. And she has also connected a vast network for those with lived and living experiences who support advocacy efforts. And not only that, she also supports those who want to work towards best practice guideline development, collaborative decision-making, and other awareness campaigns and research initiatives. MOIRA is currently the Senior Advisor for the Public and Patient Engagement at the Canadian Medical Association, and she's also a sessional instructor with the Carleton University School of Social Work. So with those introductions out of the way, let's now give the space for Bobbi Jo to share her story.
Thanks so much, Judy. So as mentioned, I am living in Edmonton. I am a mom, wife, and a teacher on disability. And despite being physically fit and leading a healthy lifestyle, I was diagnosed with non-obstructive heart disease, like Judy said, after almost a decade of self-advocacy. So my symptoms started with periods of extreme fatigue, flu-like symptoms, and chest pressure, lightheadedness, nausea. And unfortunately, at the time, due to lack of awareness on my part, I didn't know these symptoms could be signs of heart trouble. So I just basically tried to self-care my way through it that year. However, a year later, I had my first big heart episode that sent me to emerge with squeezing in my left chest, pain down my right and left arms, pain in my shoulder blades, my jaw up into my teeth. My ECG showed that my heart was not getting enough oxygen, but the rest of my tests were deemed to be normal. So I was sent home with a muscle relaxer and tips on stress management. And I continued to have these episodes daily and presented very similarly to the emergency. So for the next 2 years, it was a revolving door of cardiologists, specialists, ER physicians telling me it's not your heart, it's stress, you're somatizing. Despite some classic signs of non-obstructive heart disease that I now know, time and time again, I was reassured that there's no way it could be my heart. And I was too young, too fit, and too healthy for heart disease. Basically, I didn't fit the picture. I was given the $1 million workup several times over during this time. And it was deemed that my abnormal ECG results were from a normal variant, despite never having an ECG at baseline without chest pain. So I was sent for psych referral after psych referral and offered a battery of antidepressants. I saw so many specialists to investigate my stomach, my brain, my lungs, my reproductive organs. But at that time, I knew it was my heart. So it was a very frustrating and isolating time for me. I must have seen over a handful of cardiologists during this time, but I was lucky enough to find one here in Edmonton who truly did want to help me, and he refused to give up on me. He's still in my corner to this day. However, due to barriers in research and testing and treatment, he was left scratching his head when all my tests were normal and when I wasn't responding to treatment appropriately. So in 2016, I found the name of a women's heart health specialist in Vancouver, Dr. Sedlak, via an online support group for women with non-obstructive heart disease. That support group was my lifeline at the time, and I don't know where I would be without it. And this is kind of the point where things started to change a little bit for me as far as being believed. Although it was still a battle at the Emerge here in Edmonton and with certain local specialists. But honestly, for me, not being believed and being made to feel like I didn't know my own body was just as traumatic as being ill. And unfortunately, that has had some long-lasting emotional effects. So I did finally receive an official diagnosis in January of 2020 after a new type of test. So a new angiogram was offered in my city. I credit this to Dr. Sedlak for giving me the information and allowing me to have that opportunity, because she told me what was happening, where the test was being offered, and who to contact. This particular angiogram is only offered, I believe, in 3 to 4 sites across Canada. It is invasive. It carries risk, but right now it's all we have. So due to the fact that my condition is understudied and more research needs to be done, I've not found a medication that has helped me get my life back. So I just watch my triggers. I rely heavily on pacing and accommodations. And I guess what I want to say at the end is just that the reality is that the doctors don't know what the research doesn't show. And I know that now, but unfortunately, women's heart health is grossly understudied. It's up to us as women to take control of our own heart health, know the signs, know the symptoms, and know our risk factors so we can be proactive and empowered to advocate for our own best care.
Thanks so much, Bobby Jo, for that really compelling story. You obviously identified several barriers to, optimizing your own heart health care. You've touched on lack of awareness, both from your healthcare providers, emergency care, doctors, etc. You talked about limited access to healthcare services that wasn't available in your region initially, and many others. What are other barriers that you think were that impeded your achieving that optimal level of care, and what were some ways that you found as a patient to move forward, or some ways that you think you can share with our audience how you can break down those barriers?
Sure. So as mentioned, my first barrier truly was the lack of shared awareness. So I didn't know my symptoms could be heart related, nor did my treating physicians identify my symptoms as such. So I had to educate myself, and that was the first thing that I had to do. So this is why it is so important to know the signs and symptoms of heart trouble specific to women, as well as women's specific risk factors. Also, in the early days, the language that I used wasn't always clear when I was trying to describe my symptoms. I have since learned to be more concise and refrain from making excuses for my pain or apologizing for being there. I also wish I would have started a symptom journal earlier in the process, because what I found was at the time I was so overwhelmed and so scared that I kind of forgot a lot of the warning signs that my body and my heart was giving me. So when it came time to let my physician know, I really went blank. So symptom journals are so important, and they've been invaluable for me because they can kind of help create a clearer picture of what's going on, what the triggers are for you and your physician. Another consistent barrier was not being heard or listened to, and kind of being labeled as somatizing my symptoms or making them up in my head. It took taking my husband with me to the ER to finally get a stress test, and having him there to vouch for me and who I was at baseline was invaluable. So I think that when you're kind of on the boundary of medical knowledge, absence of evidence becomes evidence. It's in your head. So for me, taking that support person with me was absolutely invaluable. And as mentioned, many of the tests that I received didn't show any heart issues at all. And the ones that did just kind of came back saying that it wasn't anything significant. And I remember arguing and kind of having a discussion with my GP, letting him know that the negative results didn't mean that my heart was fine. It just meant that we didn't have sensitive enough tests. He thought that was pretty funny. But although looking back, I was right, and that was the situation. So I had to remind myself that I was allowed to have my own opinion about my test results and my experience. And if something felt off or mismatched to me, I kind of had to give myself the right to address my concerns. And like I say, the barriers in testing have been such a challenge for me. Everything from being declined tests I felt were necessary to not having access in my province to more sensitive testing. But none of my local treating physicians knew anything about this provocative angiogram or how to access it, except for Dr. Sedlak. And then she was concerned about my risks with the procedure. So, I'm still really concerned about the lack of specialized non-invasive testing for women with non-obstructive heart disease. But saying that, I do strongly believe that all women should ask for an ECG at baseline, whether it's at a physical or at some point in your health journey, just so that you can monitor any changes that might occur throughout your lifespan. This was something I didn't have, and I wish I had had, because I think it would have detected some issues earlier than it did. So, and then the lack of women-specific cardiovascular care in Edmonton was truly detrimental to me, because as a woman with, living with non-obstructive heart disease, I was never offered rehab. I was never offered counseling. I was never offered access to local support groups. I just kind of felt I was on my own. I had to leave the province to find somebody who would listen to me and help me. And that's where I got my information from. All of my information came from my care that I was seeking in Vancouver. And it's not really feasible to travel 17 hours every couple of weeks for comprehensive care. Even now, I'm waiting years for surgery in Toronto to address a myocardial bridge because I can't find anybody here locally who will do it for me, despite having access to 2 major cardiac care centers. So like I say, many times I just feel invisible. Another thing is that I really wish I would have found Dr. Sedlak earlier in my journey, and I wish we were in the same province. Consulting with her truly was a turning point for me. She took a very detailed history. She listened to me without interruption because she knew she couldn't rely on the diagnostics to tell the whole story. So my story was of the utmost importance. I think every woman, if they are struggling with a possible cardiovascular issue and they feel they aren't being heard by their local cardiologist, should not only seek a cardiologist trained in or specializing in women's heart health, but try to find one who will move the moon for their patients. They do exist in Canada, I promise, but like the specialized testing, they are only in specific areas, so there is an issue with accessibility. So how do you find these amazing people? Webinars like this and support groups. Support groups have come a long way since my journey started. And while no one in them can give you a medical diagnosis, they can offer advice on cardiologists they've seen, tests that have been beneficial, therapeutic options, clinical trials, you name it. So I'd love to sit here and end my story with, happy news that I'm doing wonderfully and I'm thriving and everything is great. But unfortunately, that's not the case. I'm still advocating for my best care in terms of treatments that will work for me. So while I can't give you the happy ending that I wish that I could, I'm hoping some of these things can be learned from my experience. So know your signs and symptoms, know your risk factors specific for women, take an advocate with you, start a symptom journal, ask for a second or third opinion if you have to, or seek out a woman who is specialized in cardiovascular care for women, and get connected to a support group.
Thanks, Bobbie Jo. That was tremendous. If we can move to the next slide. So Bobbie Jo in her story has touched on multiple barriers and how we can achieve, cardiovascular care from her own perspective. She touched on limited access to healthcare services, lack of sex and gender specific care. But here's a list that I had put up to, identify or just to briefly summarize the different healthcare barriers for the best care for heart health for women from an intersectional lens. And when we say intersectional lens, it's really considering the multiple factors that could impact care for a woman. And so you see here that includes, race and ethnicity, considerations of their social economic status or their position. We know that women who are from lower income, vulnerable populations have more barriers to cardiovascular care. That also includes things like sexual orientation, their gender identity. And it's really including all of these things, as well as, rurality, where they live, the remote communities, to understand and to see how these different factors impact and influence a woman's access to and their quality of healthcare. And so all of these barriers that you see listed here can really impact women differently based on their unique experiences and identities. And we're going to be hearing more from our other expert panelists, some of their own experiences with these barriers. And so to address all these barriers so that we can optimize heart health care for women really requires a comprehensive approach, also a team-based approach, and really thinking outside the box beyond our own practices, and hence the purpose of this webinar. And so we need to understand all of the women's challenges from multiple angles. So we have next, and again, reminder to the audience, feel free to enter your questions. We'll be able to address all of them at the last period for a Q&A session as much as we can. So MOIRA, let me just find you here. Hi. So after hearing Bobbie Jo and her context of navigating, her difficulties as a woman with lived experience and your own experience in acute care as a social worker, and in that important space, what are some barriers that you have experienced in your profession and patients navigating that?
I guess in a nutshell, what she said, Bobbi Jo's so bang on with her advice, and thank you, Bobbi Jo, for sharing your expertise today. It's so invaluable to hear that from that lens of the recipient of care and how things look and feel from that perspective, because it's quite often not really part of the expertise that's showcased in panels like these. And so thank you for being here. Thanks, Junie, for having me on the panel today, too. Unfortunately, Bobbi Jo's experiences and recommendations have been echoed by many others I've heard from over the course of my career. I'm sure we'll see a lot of her points, in fact, come through in the upcoming Canadian Women's Heart Health Alliance Atlas chapter on the social determinants of health, which is coming up soon. And so one main piece I was hearing from Bobbi Jo also is the role of primary care and how access to primary care is invaluable as an advocacy tool. So those needing acute care, coming into that space when they have that baseline data, when they have someone to vouch for them from that profession of the physician base, it really does help contradict and counteract some of that resistance that maybe people are faced with. A national survey, ourcare.ca, showcases that of about 10,000 respondents, 1 in 5 people are without primary care providers at this moment in time in our country. And that survey is of those who can do an online survey and who speak French and English, so it could be much higher. So when you hear about that, that's one piece of advocacy that a lot of people are missing, and having someone in their corner to support their baseline factors. When I hear Bobbi Jo's points overall, I hear ultimately 3 main themes. And so one is, the historically validated fears that people may have in accessing care within the hospital. And that might be intergenerational, regarding what were once guised as institutions of care, quote unquote, Indian hospitals, residential schools. And it could also be in response to very real learned helplessness due to ongoing racism, gender bias, as Bobbi Jo has mentioned, and also ageism within the system. We also kind of ultimately hear through Bobbi Jo's experiences the intersectional structural barriers at the society level. So cultural and gender-based socialized norms and notions of not wanting to be a burden to the system, and not really being an expert regarding your own body, and how that is socialized from a very young age, especially among women. And then there are the social barriers that are echoed within research, women being underrepresented in the cardiovascular health research sample base, and then at the facility level. So that I find, especially now when there is a lack of human resources in healthcare, people are working very quickly due to the understaffing. This is where our unconscious biases thrive, within those quick turnarounds in decision making. And so we do need to make sure that we're not enacting some of those social norms and biases within our practice in acute care and across the continuum of care.
That's amazing, Moira. Thank you for really, that was just so well done in your experience as an acute care social worker. So amazing, all your experience. Like, what were some ways that you found over the years to move forward to reduce and break down these barriers? And if you had to summarize or give any feedback to the audience here who's listening, what are some of those ways that we can all help to reduce those barriers?
Again, I agree with all of Bobbi Jo's points and what she's brought forward. I think we do tend to focus on advocacy at that individual level. And I think shifting away from that neoliberal approach to advocacy is really important. So we don't want to place the onus on women to be stronger self-advocates or more medically literate when they're ill and they're in pain, when they're not healthy and feeling at their best. We really need to make sure we're enacting a more responsible approach, and individual empowerment is wonderful, but it always has to be balanced and go hand in hand with systemic change. And we need to meet people at their level, and we need to, as practitioners, be responsible for ensuring that people are aware of what's going on, and that we can work based on where they're at within their capacity of taking in new information. When you're in pain, it's very hard to process what's going on. I would say also greater diversity in the workforce is key. I mean, with diversity in the workforce comes lived experience and an understanding that's within when it comes to diversity. And so that impacts your approach to care. And we need to see healthcare workforce reflect the diversity that we have in this country, especially as we're in a human resource crisis in healthcare. We need to reduce the barriers to intake and the bias standardized testing formats that reduce the ability for those who are marginalized and oppressed to succeed within the healthcare professions and get those spots to provide care. I think also it's really important to have those trauma-informed approaches to care. Like I was saying, it's very hard to process new information when you're in pain and in a health shock. So speaking to folks with compassion, ensuring they're informed when it comes to consent, making sure people have interpreters, try not to rely on family. They may also be in shock, and it's very hard to be an interpreter at the same time as processing the information for the first time. So having translated materials, diagrams, the Canadian Medical Association's Patient Voice Advisory Group has created an excellent resource guide on trauma-informed engagement that I encourage folks to have a look at. Just two more points. So when it comes to structural reform, we need to include the recipients of care at all levels of making sure that the healthcare system is reflecting their needs. The Canadian Women's Heart Health Alliance is an excellent example of this. You know, with each sub-working group, there is a chair that has lived experience. And the CMA's Patient Voice also has a really clear definition of patient-partnered care, and it really does follow that team-based approach to care, and it's more tangible, something that's measurable, which is really important. In the meantime, while the system is catching up and while the research is catching up, I agree with Bobbie Jo that women should have an advocate with them, if at all possible. Don't wait it out and delay treatment despite your valid fears. Perhaps you have experienced bias in the past. Your life is worth it, and society needs you. Our strong women are needed now more than ever in society. So please, please seek help when you need it. And time is of the essence. So we often, as women, create safety plans for loved ones, our households, our families. Let's do some advanced care planning for ourselves and figure out, you know, if I were to get ill, who should I call? Who is my safety net? Who's my social network? Create a safety plan so that you can really enact that plan when you need to and get that help that you so desperately need.
Amazing. Thank you so much, Moira. I'd like to ask Dr. Bastiani, you know, obviously being a woman in cardiology and a woman of color, you must have had so much experience with your patients and your communities. And so what are some key learnings that you'd like to share with the audience today, you know, in this space?
Well, yes, of course. Thank you, Dr. Liu. Thank you to Moira and to Bobbie Jo for their Bobbie Jo for her testimony, and for Moira for all the information that she shared with us. I'd like to kind of like jump from what was said earlier, the importance of research. You were asking me about barriers and about things that could be better. I think that the research is super important. We are now treating women based on research that has been basically done with men, usually in research, it's something like maybe it's between 20-30% max of women included in those researches, and we apply the results to the women populations, which is problematic. And most of the time, there's no specific analysis for women and stuff like that. So I think that this definitely is something that should be improved. In my personal practice, I noticed that a lot of women did not know how important risk factors were. They did not know that they had risk factors. They did not know that they were at risk of having cardiovascular events and or stroke. So I think that knowing first that the leading cause of premature death in women is heart disease is definitely something that should be out there. It will help us raise awareness. It will help us, tell women, you are at risk, and it will help them self-advocate as well. From Bobby Joe's story, we understand that self-advocacy is super important as well. So talking about risk factors, we know that we know about the traditional risk factors, so smoking, high blood cholesterol, high blood pressure, obesity, lack of exercise. So all of these are traditional risk factors that we know put people at risk of heart disease. However, what we don't necessarily know is that they affect women more than men, which is basically what I mean is that a woman with the same risk factors will have a higher risk of developing heart disease and or stroke. So this is definitely something that needs to be kept in mind. Depression is another risk factor that we don't necessarily talk about. Even as physician, and myself first, we don't necessarily put that in our, when we meet a patient for the first time, we don't necessarily include that risk factor in our questionnaire. So depression, anxiety, which affect women more than men, and put women it gives a higher risk of heart disease as well. It gives a risk at least 50% more risk of having heart disease. So this is not a small number. So it definitely needs to be asked. People, women in particular, need to self-advocate and tell their physician, hey, you know what, these are my risk factors. They need to be aware of what applies to them. I think that's very important as well. The other thing that we don't necessarily, as physician and also as patient, we need to know that there are other risk factors. It's not only traditional risk factors. So for women in particular, there's certain things that apply to them. So we're talking about, menopause. We're talking about contraceptive, so hormonal therapy, complication during pregnancy. So we're talking about gestational diabetes, gestational high blood pressure, preterm birth, sorry. So I myself had to incorporate these things in my questionnaire when I would evaluate my patients. And still today, we see physicians that do not ask these questions, and this also needs to change. So these are basically the main things that I would mention. And even women, when they present to the emergency, 50% of women who present with a heart attack are not recognized. How is this even possible? So we were talking about symptoms earlier. I'll mention Bobby Joe's testimony, how she was saying that she would often, don't remember her symptoms. And when she would remember her symptoms, there was a lot going on, So we know now that women do have chest pain. It's not that they don't have chest pain. It's just that they have other symptoms as well. So they'll present with headache, they'll present with, shoulder pain, jaw pain, GI symptoms. So because there's so much happening, their symptoms kind of gets lost. The chest pain kind of gets lost in all those symptoms. And I don't think that not mentioning these symptoms is the key. I think that just knowing your body, knowing that there's something going on and insisting. So once again, we're talking about self-advocacy, insisting on these symptoms is super important to kind of reduce that 50% because it should be equal, right? We also know that women that have a heart attack have a higher risk of mortality, higher risk of heart failure compared to men. They don't get the same treatment either. they're not referred to rehab centers. They don't get the guidelines, the treatment that are suggested by the guidelines. They don't necessarily get all of that. So this is definitely something that we need to look at. Maybe we're talking about awareness in patients, but definitely awareness in physicians also.
Thanks so much, Dr. Bastiani. And kind of along the same lines, you know, there's different ethnic considerations for the audience. You know, a woman who they've shown data that Black women often don't present with chest pain as they're presenting symptoms, that it can be just abdominal pain, epigastric pain, or belly pain. And back to that whole stigma, that's a barrier to, you know, women who have different gendered roles at home are often the primary caregiver. And so there's a huge cultural sensitivity and cultural barrier to these women getting access. It's really hard if you're a mom taking care of a newborn to recognize that you have symptoms and be able to find that time to go to the hospital if you don't have the supports at home. And so as a woman, there are many different factors that can impede you getting that optimal care, as so many of these members of our panelists have touched on already.
Definitely. And we know that let's say for Black women, we know that there's a higher risk of cardiovascular disease. The risk factors are more predominant in the Black community. So we're talking about high blood pressure, diabetes, high cholesterol. There's a highest rate of inactivity in the Black population, and obesity as well. So that's definitely, you know, something that's particular to that population, and that's not even mentioning, you know, the generational trauma that we find in this population. Same goes with Indigenous people. So with colonialism and racism, you know, these concepts are still impacting health of Indigenous people today. They have 2 to 3-fold greater risk of having heart disease, which is not, once again, is not a small number. A lot of them live in rural or in remote communities. The economic situation is also can be also precarious, which can kind of like, how can I say that? It doesn't help with the access to healthcare, basically. So this is definitely something to keep in mind when we address patients from the BIPOC community, so Black and Indigenous community. It's important to take the time, question them, and take into account the social and economic factors of these patients.
Thank you so much, Dr. Bastiani. And then, so TAIRA, onto that point, you know, Dr. Bastiani mentioned multiple barriers, including, you know, stigma, discrimination towards you know, race, ethnicity, cultural sensitivities, and then she spoke about the rurality, the remoteness of delivering care and getting that access to care. And so, in your experience, you know, wealth of experience with cardiac rehab, which I'll let you explain and share that space. What are some of your barriers you find in terms of optimizing cardiac rehab for some of your patients?
Yes, thank you. Cardiac rehab, you know, it's my world, and I look at it and think we're a huge nation, huge landmass, you know, all different kinds of physical environments, cities, urban and rural. Cardiac rehab is very limited, typically as to, you know, where it's offered, how to access it. We look at cardiac rehab, and you know, it's a very important piece of the process for we call secondary prevention. So after someone's diagnosed with cardiovascular disease, but we also get people with primary prevention, with risk factors for heart disease, right? We want to prevent the disease in the first place. So we look at cardiac rehab, you know, it includes exercise, psychosocial supports, nutritional counseling. We manage risk factors like diabetes, cholesterol, blood pressure. So it's very inclusive and covers so many different factors, but it's not typically or understood to be accessed by everyone. So although it is extremely important and valuable, and women, just like, they're underrepresented in research, they're also underrepresented in some of these secondary prevention, including cardiac rehab. So we need to figure out, better ways to deliver cardiac rehab, to open it up to people across the country, giving options. Women have so many barriers that hinder them from getting involved in the education and learning about the risk factors. There's financial barriers for cardiac rehab. It's not consistent at all across the country, not even in the city that I live in, whether how the funding goes, how they're run, how they're supported financially. Some have, require pay for service fees. Our program, we do a lot of fundraising to help support our program, to provide subsidies, otherwise people pay. So we have people from different socioeconomic levels as well, but everyone benefits from cardiac rehab, women and men. Women also, sometimes don't feel like this is a place for them, especially, younger women like Bobbie Jo, who have, they're not a typical cardiac patient, right? And I think a lot of there's bias in thinking about what cardiac rehab is. Is it, older people all the time? Cardiac rehab really can affect or can benefit people of all ages and genders and ethnicities, but we need to be culturally sensitive to their needs, to people's experiences coming in, how they're going to be comfortable, even with exercise and activities, right? Just like not everyone is a marathon runner, right? We need to think about what kind of activities will help people, increase their physical activity. What are they comfortable doing? What's culturally appropriate and for them? So, we need to listen a lot to people, to all of our participants. The other financial barriers for transportation. If you don't have a program with an easy access, you need to transport there. You have a vehicle or transport services. It may just simply be so incredibly far. It's not at all an option. So we look at, okay, even if you can go, often women are caregivers. They're mothers, sisters, caregivers to other people. So, it's time management, being able to juggle their time to care for themselves, which a lot of women put themselves at the bottom, and they care for so many others beyond themselves. So we need to think of those things. How can we make it more accessible for women when they also have they're juggling many things? Looking also at, how do we access, if I'm not within a close location, do we have home-based options that we can do? Are there virtual options we can do? And then we even think about rurality, living in far away, there are places that don't have internet, right? We just don't have access to these tools. So we need other tools to be able to help people, learn about risk factors, how to exercise safely, increase their activity levels, and also in different, depending on your language, you need translation services. So it's very complex. It's not impossible. There are many things we can do and things that have worked. With a women's only rehab program, we're able to really be more inclusive of women, creating a more women-centric area and participate in exercise and the education, and also provide women-specific education. But I'm very understanding that this is not accessible across the country at all. There are areas that are doing extremely well at this, but we need to be able to share more information. These kind of panels I love because it's sharing, sharing experiences, hearing from others what works and what we can do better. So those are some of my, I guess, my wish lists and experiences of working with women specifically.
Thank you so much, Tara. That's also amazing. You touched on so many of these barriers from an intersectional lens and definitely ways that we can improve it, from rurality to, offering navigation services, with, you know, helping with the financial, how to navigate that, you know, food insecurities, all that stuff. There are some questions in the audience that we can briefly touch on. A lot of them have been addressed already. Some of them may not be pertinent to our webinar today on improving healthcare burden. And some of the more personal questions, I do advise you to speak to your own family physician or your own cardiologist. But there's a question here at the end, you know, this kind of has come out in the themes, like how does a woman overcome barriers or obstacles experienced in the ER emergency department so that their symptoms can be taken seriously and for them to not have an assumption and the patient's symptoms are minor, like panic attack, stress related or weight related, and what vocabulary can they use to advocate for their own heart health. I think Bobbie Jo and Mara has already touched on this in terms of what certain vocabulary, but if each of you can think of one word that you could share so that that woman could advocate for herself, what would it be? And maybe I'll start with Bobbie Jo or Mara. What would that one word be that they could use for that vocabulary so that they can advocate for their own heart health? Bobbie Jo's off. So maybe Mara, I'll throw that question to you.
Okay. Yeah, I would say it's reiterating as much as possible that this is not my norm. This is not normal. This is not my baseline.
Great.
And you know, it's interesting when you think of pain scales for those who may have had a natural birth, their 10 out of 10 might be a very different 10 out of 10 than someone who has not. And so, you know, using some of the spectrums that the facility has, I've often said it's a 15. 10 was childbirth, this is a 15, or give it a bit of context. What does the 10 out of 10 mean to you? Based on your worst pain, where are you at? It gives people, it really brings the message home. It's not just a number, but it's basically showcasing where you are within your norm. And so, yeah, I mean, it's a tough one, but it's staying firm on that for sure.
And I know, Dr. Bastiani, you have to go. So what is your, you know, in your experience, what is that vocabulary that women can use to advocate for their own heart health? Question from the audience there.
So I think that Moira basically touched on everything. The only thing that I would add would be to express how scared they are, how concerned and scared they are, because unless your physician is a monster, whenever a patient says that they're scared and concerned, usually people pause and try to dig deeper. So that would be that I would just add that maybe.
Great. That's an excellent answer. And then Bobbie Jo, anything to add to that?
The only thing that I would add, all amazing answers, but the only thing I would add that is, if you think it's your heart, say that. I think it is my heart. Instead of, I think it's indigestion, I might have hurt my shoulder moving something. If you think it's your heart, say that. I think it's my heart.
Great.
Yeah, definitely. And that brings me back to the idea that, you know, I keep saying that to my patients. I tell them, you know, it's not your job to find the answer. Your job is to tell me your symptoms, is to tell me what you're feeling, how you're feeling. And my job as a physician is to find the diagnosis, to find what is going to give me the answer. Because, you know, sometimes they come in and they're like, you know, I think it's that, I think it's that, or they're like, I don't know what it is, doctor. And I tell them, listen, it's okay. It's okay if you don't know. Give me your list. And I like the idea of the journal because that helps us as physicians to understand, you know, when the symptoms happen, what is around this, like, you know, what were you doing before? What were you doing after? How did it stop? When did it stop? These things help us understand the symptoms better and come up with, you know, a differential that makes sense. So yes, if you think if you think it's your heart, you absolutely 100% you should tell your physician, I am concerned that it is my heart. But please, as patient, don't feel like you have to come up with an explanation because it's not your job. Your job is to go and explain to your doctor what's going on. I think that's important to know.
And then TAIRA, anything else to add to that in terms of the vocabulary that women can use?
I agree. I think it gets tricky because, you know, women have some different symptoms than men. I always tell our clients, you know, chest pain, absolutely, if you have chest pain, you tell it, but I think you get to know what is different for you. Like, what is my body telling me? Be as clear and concise as you can. But again, I think, like Bobbie Jo, you can't persist, and it's hard because at the time you're tired, you're stressed. This is, you want someone to just figure this out for you. But just be persistent, don't get down, be positive, and you may need to reach out for more supports, like Bobbie Jo did. Unfortunately, sadly, this is not, I hear this story a lot, and it's not acceptable, actually.
Okay, great. And just keep in mind of the time, if you go to the next slide. Thank you, everybody. So as you have all heard from our panelists already, we just were able to touch on just the tip of this iceberg of the different barriers. A lot of it is around awareness of symptoms, both from the patient perspective, their families, and their healthcare professionals. That's the whole purpose of this webinar, and the whole purpose of the Alliance is to really raise awareness and launch campaigns for this purpose. But here's a quick list of ways that we can improve barriers together. Again, the first one is already well touched on about awareness and education, both for yourself, advocate for yourself, standing up for yourself, for your primary care providers, and insisting that it is your heart, and your family members, letting them know. Ways we can improve barriers are also to improve access to healthcare, and some of this was touched on, increasing the availability of clinics, providers, specialists, offering virtual platforms to reach the remote and rural communities. And then not yet mentioned on, but something that you can think about in your own community is offering childcare services with the clinic visits. If you're a mother with children, it's really hard to go seek help when you have to think about childcare. And then for the healthcare providers out there to also think about flexible clinic hours, so that people who have jobs at different time of the day can attend these clinics. Again, number 3 is already touched on by a lot of the expert panelists, providing sex and gender specific care that addresses female specific risk factors and being aware of them. And then if you are also a patient, to also be aware of them too, so that you can advocate for yourself. I had mature menopause at the age of 40. When my ovaries were taken out, I am at risk of heart disease. Please give me a proper risk stratification. And then for, I think Dr. Bastiani, as well as TAIRA, spoke about this too, about breaking down those stigma and our systemic biases that we have from multiple or stereotypes that we have, and just, letting them go and just be very, very culturally aware. And then number 5 on the research. So there needs to be increased representation of diverse multi-ethnic women in research. And this is another big pillar, another big mandate of the Alliance. And together, I think everybody on this webinar can help with that. And then finally, number 6, that's why we have such a large expert panelists here. We're trying to build the partnerships, not only between healthcare providers, patient advocacy organizations, which is the Alliance here, but as well as other community-based organizations in your own community. I think together we need to work as a team to raise awareness for women's heart disease and to overcome that increasing mortality for women and cardiovascular disease. And then I finally here, this point in black and bold is to really note that all these barriers, in order to overcome them and improve them, they have to be taken from a perspective that's both culturally sensitive and recognizing that women have different diverse backgrounds and experiences, and that we should be aware of them and believe them and support them through their journey, both with heart disease or who are at risk of heart disease. So if we can move to following just to wrap up in the last 3 minutes here. We move to the so we have answered a lot of the questions. A lot of them have been answered. Some of them are quite specific. So, Helen, Van, so I won't call it names, but some of the questions are very specific to your own condition. So I do refer you to your own cardiologist and your own family physician. To the chat box, there's been a lot of resources sent out. And so I do refer you to clicking those links. A lot of them can be helpful to your own question. And then let me just see here. So yeah, and we will try to answer as many of them as we can, but if not, there'll be a follow-up email to the registrants. So we just definitely need more time. Some of them are, again, more specific, but a lot of them we will try to reach out in a big follow-up email to answer those questions. And then finally, in the next slides, yeah, go ahead, Melissa.
Wonderful. Yeah. So thank you again to all our panelists, and thank you for all our questions. There were many. And so we will be sending out a follow-up email with all of those links and resources. So don't fret if you feel like you've missed one. But before we close out today's webinar, we would like to highlight a number of other resources and initiatives that might be of interest to you. First being the Canadian Women's Peer Support Heart Hub, which was launched late last year. We are aware that women living with diseases of the heart and blood vessels need more than medical care. Peer support empowers women and provides a safe place to meet, bond, and share experiences, and can come in many forms. So if you want to check out the Canadian Women's Peer Support Heart Hub to connect with other women in peer support programs and services that are right for you, you can visit womenshearthub.ca. Next, we will just touch upon the Canadian Women's Heart Health Alliance's educational videos. So the Alliance is creating a library of educational videos highlighting various cardiovascular diseases and conditions and risk factors. If you visit our website, you can view and please share these videos with your networks, and you can see a few of them on the screen, but there are more to come, and they will also be available in French. Next, we have our Women's Heart Health multilingual resources. So if you've been watching social media today or have heard of We're With Canada before, you know that we've got 5 key messages. And in order to reach more women across Canada, particularly those who are at higher risk of heart disease, the Canadian Women's Heart Health Alliance, or CWHHA, has created these multilingual resources. These address symptoms of heart attacks for women, causes of heart disease for women, risk factors for women, and ways to reduce your risk of heart disease. Now, these were created using Chapter 2 of the Atlas, which was previously mentioned in this webinar, but we can also send that link in the follow-up email. Our target audience is our Indigenous, Black, Hispanic, South Asian, East Asian, Chinese, North American, and all women with this project. It is a multi-phase project, with the first phase being to translate and adapt, like I said, the We're in Canada key messages, and they're currently available in 15 languages, which include English, French, Arabic, Creole, Hindi, Inuktitut, traditional and simplified Chinese, Portuguese, Punjabi, Spanish, Tagalog, Vietnamese, and American Sign Language, as well as Quebec Sign Language. And coming soon, Swahili. So please feel free to check those out. Next, we have our Canadian Women's Heart Health Summit. So it's coming up this April. Mark your calendars. It's proudly hosted by the University of Ottawa Heart Institute, Heart and Stroke, and the University of British Columbia. The Canadian Women's Heart Health Summit is the only event of its kind and has become the national reference point for health professionals seeking up-to-date knowledge of women's heart health. On building on the success of the 3 previous summits, 2016, 2018 and 2021, we are assembling national and international experts and stakeholders to help further advance women's heart, brain, and vascular health. It's an accredited opportunity for knowledge exchange for a variety of stakeholders, including primary care providers, cardiologists, neurologists, gynecologists, pharmacists, nurses, but check out our website. It's womensheartsummit.ca, and it's taking place in Vancouver, BC this year with some virtual options, April 28th to 29th. And please, again, visit womensheartsummit.ca for all the details. Lastly, it is We're in Canada, but it's not too late to sign up for our movement challenge. It starts today and it goes up until the 28th, but you can register and get active and help raise awareness about women's heart health. And what you can do is track your progress towards a cumulative distance of 5 kilometers or 10 kilometers, or 30 or 60 minutes of physical movement of your choice. You can sign up as an individual or as a team, but we encourage you to get your family, your friends, coworkers involved. And upon entry, you can receive a Wear Red Canada branded t-shirt and a medal and a certificate of completion. So I believe my coworkers throwing in those links in the chat there, but please feel free to visit wearredcanada.ca and you'll find all those links there as well. So with that, thank you everyone for taking the time today to share your knowledge and everyone who attended this session. Before we end, we would just like to remind you there is going to be a post-webinar evaluation sent out in an email. It'll also hopefully appear in your browser window. And virtual and in-person events are being held across the country today. Check out our website. You can join a yoga session, many educational virtual webinars, some are in person, but be sure to check out the find an event section. And many questions were asking if this is being recorded. Yes, it'll be available on our website in the next few days. Please feel free, if you have any questions, email us at cwhhc@ottoheart.ca. So with that, thank you for joining and have a wonderful Wear Red Canada.
Thank you, everyone. Bye.